Hello and welcome to our program. I'm Patricia Stark, and today we'll be discussing changing the game for patients with extensive stage small cell lung cancer through multidisciplinary collaboration, as well as best practices to optimize immunotherapy-based approaches and improve patient outcomes. Today, I'm joined by a great faculty, starting with our chair, Dr. Stephen Liu, who is a medical oncologist from the Lombardi Comprehensive Cancer Center at Georgetown University. Dr. Jonathan Goldman, also a medical oncologist from the UCLA Johnson Comprehensive Cancer Center. Dr. Kristen Higgins, a radiation oncologist from the Winship Cancer Institute of Emory University. Dr. Joanna Grace Manzano, a hospitalist from the University of Texas MD Anderson Cancer Center. And Dr. Gerard Silvestri, a pulmonologist from the Medical University of South Carolina. We appreciate all of you being here today and sharing your expertise. Now let's take a look at what we'll be covering today. In the first segment, we'll put a spotlight on extensive stage small cell lung cancer as a rare and aggressive lung cancer with exciting new therapies that can improve patient outcomes. Next, we'll explore how we have been finally making strides in extensive stage small cell lung cancer with immunotherapies, and what evidence is supporting the use of immunotherapies to improve outcomes. After that, we'll transition to discussing the practicalities of immunotherapy use and effective care coordination to improve outcomes in patients with extensive stage small cell lung cancer. And the panelists will highlight what the implications and recommendations are for the multidisciplinary team. Finally, our faculty will share their conclusions, reflections, and key takeaways. Okay, let's get started with our first discussion topic. Lung cancer is a relatively common cancer, and we've all known someone touched by this terrible disease. Today, we'll be discussing small cell lung cancer. Dr. Liu, how is small cell lung cancer different from non-small cell lung cancer?
Well, certainly histopathologically, under the microscope, the biopsy specimen has a very different appearance than non-small cell lung cancer, so it is relatively easy to diagnose. It's one of the small round blue cell tumors. There's a very strong link to smoking. So while small cell lung cancer is less common than non-small cell lung cancer, accounting for about 13% of new diagnoses, the incidence will vary significantly from place to place based on rates of smoking. As you know, it's an exceptionally lethal subtype of lung cancer, and biologically, this is one that moves very quickly. Symptoms occur very fast, and unfortunately, this cancer is characterized by early spread. As a result, surgery is generally not a good option for this cancer. We will use radiation in combination with chemotherapy for earlier stage small cell lung cancer, but for advanced or extensive stage small cell lung cancer, which is our focus today, systemic therapy is really the primary treatment modality.
Thank you, Dr. Liu. You mentioned biopsy as a means to establish a diagnosis of small cell lung cancer. Dr. Manzano, when you see a patient with a suspected lung cancer, who do you refer them to?
Thanks, Patricia. So the very first step is certainly to establish histopathologic diagnosis, and it's often a very individualized approach. So what I would normally consider would be possible metastatic sites. This is where available imaging is particularly helpful. If we were able to confirm pathologic diagnosis and establish stage of disease in one tissue sampling procedure, that is probably the most ideal. Accessibility of tissue is also important. So to answer your question, we may refer to interventional radiology for image-guided biopsy, or in other institutions, surgery might be able to assist through a surgical biopsy, although these are less common. And again, depending on where the tumor or suspicious lymph nodes might be located, very often we would involve a pulmonologist like Dr. Silvestri to help obtaining a biopsy via bronchoscopy.
Yes, and thank you, Dr. Manzano. So most of these tumors are large and central and very easy to get to via bronchoscopy. And again, as Dr. Manzano mentioned, we want to diagnose and stage simultaneously. And lung cancer likes to go to the brain, bone, liver, and adrenal glands. So if, for example, there's a large liver mass or multiple liver masses, we'll ask for interventional radiology to do a percutaneous biopsy of the liver. However, if it's central, we normally do a bronchoscopy, which is very safe and can provide tissue. Sometimes if the mass is in the periphery of the lung, we'll ask for CT-guided biopsy. CT-guided biopsy is an excellent tool. It does have a pneumothorax rate of about 15%, of which 6% require a chest tube, whereas bronchoscopy will have a much lower rate of pneumothorax. So if it's a central lesion, generally endobronchial ultrasound with fine needle aspiration is warranted. And Dr. Higgins, I was wondering if you can mention about the rapidity with which these tumors can present.
Yeah, and because small cell lung cancer is such a fast-growing tumor, it's very important to obtain the diagnosis quickly and efficiently, and also to involve the multidisciplinary care team as soon as possible so that you can really get the patient plugged in with the doctors that they need to see if they're in the hospital and they're getting discharged soon. You want to get those appointments scheduled as quickly as possible so treatment can move forward.
Thank you, Dr. Higgins. Dr. Goldman, can you describe the typical presentation for extensive stage small cell lung cancer?
Absolutely. While there is a range of growth rates for non-small cell lung cancer, small cell lung cancer is more predictably and consistently rapidly growing, such that symptoms may be worsening week by week or even faster. For that reason, annual CT screening, which has actually made significant impacts on mortality for non-small cell lung cancer, is less impactful for small cell. Patients often present with both systemic symptoms, fatigue and weight loss, as well as localized symptoms. This can be bone pain or liver pain, as well as due to the central location of the tumors in the chest and mediastinum, vascular or respiratory compromise.
And you know, from a respiratory standpoint, we often see these patients develop post-obstructive pneumonia, dyspnea, severe cough, hemoptysis, and depending on how central it is, they can develop superior vena cava syndrome and pleural effusions, all of which can lead to worsening respiratory symptoms. And this is made worse by the fact that most, if not all, of our small cell patients are smokers, so they may have underlying COPD already and develop those symptoms on top of that. Now, the one other place they can develop symptoms is they can present to you with neurologic symptoms. And Dr. Higgins, could you please talk about that a little bit?
Sure. So about 60 to 70% of all patients with small cell lung cancer will develop brain metastasis at some point throughout their cancer. It's important that you do the proper staging workup so that you can detect these brain metastases. MRI with gadolinium is the standard staging procedure to detect brain metastasis. It has the highest sensitivity. A CT with IV contrast will not necessarily detect small brain metastasis. You'll really only catch those larger brain metastases that are causing symptoms. When we have patients with brain mets, certainly they can many times have symptoms such as headaches, presenting with seizures, focal weakness, problems with vision, problems with gait. So it's very important that you obtain that MRI to see if there are brain metastasis. Now, on the other hand, if you get an MRI and there are just a couple small sub-centimeter metastases, those patients may not have any symptoms at all. And the treatment can vary somewhat depending on the clinical presentation of the patient. I will also mention that not every neurologic symptom is due to brain metastasis. Small cell lung cancer can also involve the spine, and it can press on spinal nerves that can also cause neurologic symptoms as well. So sometimes spine imaging is also warranted at diagnosis.
Small cell lung cancer is also sometimes associated with paraneoplastic syndromes, which can mimic a lot of those same neurologic symptoms. Endocrine syndromes are quite a bit more common: SIADH, hyponatremia, Cushing's disease, hypercalcemia. But the neurologic syndromes, while perhaps less common, are often underdiagnosed and can really be devastating. These are immunologically mediated, as this table illustrates, and really the course of these may not mimic the course of the cancer itself. So important to identify these as very important syndromes with small cell lung cancer.
Thank you, Dr. Liu. Today we're discussing extensive stage small cell lung cancer. Dr. Manzano, could you walk us through the staging process, please?
Sure, I can do that. So staging workup typically includes imaging specifically at CT of the chest, abdomen, and pelvis with IV contrast. That would give us an idea of the stage already. We would complete the staging by obtaining an MRI of the brain, like Dr. Higgins mentioned. And if that's not available in your institution, a CT imaging of the brain with IV contrast can be obtained. We should also consider PET-CT if available in your institutions, and this will help identify all sites of disease involvement. But having said that, we do have to note that because of the rapid course of this disease, it's not uncommon that these patients end up in our emergency room and subsequently get admitted for acute issues. And that may mean that that is where and when their initial staging and workup begins. Unfortunately, not all institutions will have all the staging modalities available. So we just want to emphasize that once that diagnosis is made histopathologically, and if distant disease is noted, completing the rest of the staging workup should not delay initiation of treatment.
Thank you, Dr. Manzano. Dr. Higgins, do you then use the TNM staging system as we do for non-small cell lung cancer?
So the answer is yes. It is recommended that you stage a small cell lung cancer patient with the AJCC system. However, historically, there has been a second staging system that was used and developed by the VA Lung Study Group. And what this staging system did was to essentially divide patients into limited stage small cell lung cancer and extensive stage disease. And what that essentially means is a patient with limited stage disease has non-metastatic cancer. The true definition of the VA study group was cancer that is treatable within one radiation port. Now, I'll say the radiation technologies have changed so much over the years that definition is really antiquated now, but yet it is still used in terms of determining whether or not patients are eligible for certain clinical trials. And again, the real distinction is metastatic versus non-metastatic. And metastatic small cell is termed extensive stage, while non-metastatic disease is termed limited stage.
That's exactly right. Accurate staging is critical to appropriate therapy. When indicated, getting radiation started with the first or second cycle of chemotherapy is very important to optimal outcomes.
Thank you, Dr. Goldman. That's an important point. Once we establish a diagnosis of small cell lung cancer and after we confirm extensive stage, can you comment on management, Dr. Liu?
Sure. Well, immunotherapy really has changed the standard of care for small cell lung cancer. We'll talk more about that later in the program. But prior to the introduction of immunotherapy, our standard treatment for extensive stage small cell lung cancer was chemotherapy. Chemotherapy alone was a standard unchanged for several decades. The chemotherapy we used was platinum, either cisplatin or carboplatin, in combination with etoposide. And this regimen has very high response rates, north of 60%. About 10% of people will have a complete response. And the regimen itself, fairly well tolerated, easy to administer. But relapse rates are very high. Progression-free survival limited to about 4 months. So most patients progressing during or shortly after completion of chemotherapy, survival consistently limited to the 8 to 10 month range. Patients that we see with small cell lung cancer present often very sick, very symptomatic. And when we administer chemotherapy, sometimes after just one cycle, patients feel better. And in that sense, it can be very rewarding, but this cancer consistently and quickly relapses. These responses simply don't last.
And when the cancer relapses, it is often very difficult to treat. We have a few options. Topotecan has a marginal but meaningful benefit in survival and quality of life. The response rates have been reported at 20 to 25%. Lurbinectedin is a drug derived actually from a marine animal, and response rates in a single-arm trial were 35%. And based on that, in the spring of 2020, this drug received accelerated approval from the FDA.
Thank you, Dr. Goldman. And so small cell lung cancer is a very chemosensitive disease, at least initially. Is there any role for radiation, Dr. Higgins?
So along with being chemosensitive, small cell lung cancer is also very radiation sensitive. So many times we will use radiation to treat painful bone metastasis, for example. Also, if the cancer in the chest is compressing the superior vena cava, we will sometimes use radiation to stop that obstruction. And patients tend to respond relatively quickly, and you can get alleviation of symptoms in a rapid way. However, because patients do respond quickly to chemotherapy, I would say more often than not, we will start patients on chemotherapy when they are initially diagnosed to get that response to treatment as quickly as possible.
And I would agree with that, Kristen. In addition, I think there are two other things we can use for very centrally obstructed tumors. The first is bronchial stenting. So if you have the availability of an interventional pulmonologist, we can do a bronchial stent in the left or right mainstem bronchus as well as the trachea. And also there are vascular stents that can be used for the superior vena cava syndrome, which can be really helpful to patients on both ends. However, because small cell lung cancer is so chemosensitive, we would go with that first prior to trying either a vascular stent or a tracheobronchial stent.
Agree with that, Dr. Silvestri. It is a very chemosensitive tumor, and as Dr. Liu described, the response rate is so high and responses can actually be fairly rapid. So when we make the diagnosis of small cell lung cancer in the inpatient setting, for example, or if a patient is admitted prior to initiation of therapy, if the diagnosis was made as an outpatient, because of its rapidly progressive behavior, it's not unusual that our oncologists will urgently begin the first cycle of treatment as an inpatient, even in patients who may have poor performance status and presentation.
Yeah, that's an important point, Dr. Manzano. We always weigh the pros and cons of chemotherapy, but small cell lung cancer can be exquisitely sensitive to chemotherapy. Because of that, patients will feel better with chemotherapy. Chemotherapy will actually improve quality of life. This is a disease where we really can make a positive impact, at least initially. And that nihilism that we often see with small cell lung cancer, I think, is inappropriate. This is a disease where we have to act. Now, while inpatient diagnosis and treatment is relatively common, this is a cancer that is often diagnosed as an outpatient with an elective biopsy, perhaps with Dr. Silvestri. And when my pulmonologist makes a diagnosis of small cell lung cancer, he will call me directly as soon as he gets that pathology report, no matter what time of day, even if I'm on vacation, because he wants to proceed urgently. I'm sure you get those calls as well, Dr. Goldman.
Definitely. And I agree with all those points. I think in the hospital, we often want to start with chemotherapy, even in a bedbound patient. Often. And in the outpatient, you want to get insurance going. You want to get the patient in as soon as possible, ideally starting chemotherapy within a week or sooner.
Thank you, Dr. Goldman. Dr. Silvestri, has that been your experience as well, that patients note improvement very quickly?
It has. I think the really important thing here is, this group is a group that treats lung cancer all the time. Pulmonologists, in fact, about 25% of pulmonologists only see 1 to 4 lung cancers in a month, and some of them even just one, and it might not be small cell. And so I think pulmonologists have had a nihilistic attitude about lung cancer diagnosis and referral. And so while Dr. Liu's pulmonologist calls him immediately, and I call my oncologist immediately, I can't emphasize enough that pulmonologists need to refer immediately when a diagnosis of small cell is suspected or made, and it will help patients so much, particularly with their quality of life and their outcome, their long-term outcome.
Thank you, Dr. Silvestri. I know you mentioned chemotherapy is well tolerated. Dr. Goldman, can you discuss some of the toxicities you would expect with a platinum etoposide regimen?
Absolutely. It's one of those cases where it's very gratifying as a medical oncologist. Patients feel better so quickly that actually that's much more noticeable than the side effects in most cases. A hair loss at about a month is something that they'll notice clearly. Low blood counts, white cells, platelets, and anemia can all be present and progressive over the course of chemotherapy. There are some rare side effects if you use the cisplatin agent that aren't seen as much with carboplatin, such as hearing loss, nerve damage, neuropathy, as well as effects on kidney function. There is sort of general side effects like low appetite and weight loss and fatigue. But generally speaking, one of our better tolerated regimens.
Right. You did mention the Tripnic fever earlier as one of the cytopenias that we commonly see in these patients. We see this very frequently on the inpatient side. So I'll just mention a few kind of principles. These can sometimes turn into neutropenic sepsis. So patient education for signs to watch out for that should prompt immediate medical attention is really very important for patients receiving these chemotherapeutic agents. We do risk assessment for complications, very prompt evaluation for any organ dysfunction, infectious workup, of course, and prompt initiation of appropriate IV antibiotics in order to get the best patient outcomes.
Thank you, Dr. Manzano. Once 4 cycles of chemotherapy are completed, you mentioned that the risk of relapse is very high. Can anything be done to mitigate that risk, Dr. Liu?
Well, that's what we're working on. Getting that initial response is pretty easy. The response rates are quite high. It's maintaining that response, the durability of that response, staving off relapse that's really been the clinical challenge. Maintenance chemotherapy or switching to an alternate chemotherapy, it's really been largely ineffective. And we'll talk about immunotherapy a bit later, but our standard after chemotherapy have been close monitoring with CT scans, MRIs of the brain. We know that the brain is an important reservoir site, an area that's very prone to relapse. So contrast-enhanced MRI is an important part of surveillance. Historically, we'd addressed the brain as a reservoir with prophylactic radiation, but I think that's starting to fall out of favor based on some more recent data. Maybe Dr. Higgins can explain a bit about prophylactic cranial radiation.
Sure. So PCI was developed several decades ago to offer patients a potential route for reduced brain metastasis down the road in their disease course. And it had been shown to improve survival in patients that had limited stage small cell lung cancer by an absolute value of about 5%. So PCI is standard of care in patients with limited stage small cell lung cancer after they get chemoradiation. However, let's look at our extensive stage small cell lung cancer patients. In those patients, we standardly would not do any sort of brain treatment until a trial was done in Europe to assess the utility of PCI in that patient population. Now, again, remembering this trial was done in Europe, patients did not undergo a brain MRI when they entered into the trial. And what the trial did was compared PCI versus no PCI. And they found that patients that got PCI did have an improvement in survival. Now, I will say in the control arm, patients did not get any brain imaging standardly. They did not get imaging unless they had symptoms. So for a while, a small amount of time, PCI was standardly recommended by radiation oncologists for extensive stage small cell lung cancer. However, there was then a trial done in Japan that had a similar schema. However, the trial required all patients get a baseline brain MRI prior to entry into the trial. And in the control arm, patients would get just observation and brain MRI every 3 months. Patients then received PCI, again, similar to the Slotman trial. And what it showed was that there was no difference in overall survival. Certainly, if patients developed brain metastasis, they would then go on to brain-specific therapy with whole brain radiation. But this trial really was a turning point for PCI in extensive stage small cell lung cancer because essentially we don't have to expose our patients to the side effects of prophylactic cranial radiation, and we can just observe the brain as long as our patients are getting that MRI every 3 months so that if they do develop brain metastasis, we can come in early with treatment.
Yes, Dr. Higgins, I agree completely. I do find that this question still is somewhat controversial, both in academia as well as in the community. But I was also very convinced by the Takahashi trial, showing that there wasn't a clear benefit to PCI in extensive stage. There are, thankfully, some more ongoing trials that may clarify this further, including the ongoing Maverick trial, which we're looking forward to very excitedly.
Thank you, Dr. Goldman. Local relapse is also a concern in small cell lung cancer, correct, Dr. Silvestri?
Yes, that's correct, Patricia. And sometimes for a pulmonologist, it can be hard to differentiate what that causes. And so we think about 4 or 5 things. One is just progression of disease. The disease has come back centrally and it's progressing. The second is post-obstructive pneumonia. And so when we see patients with fever in addition to their There are other symptoms we think about pneumonia. There's also pulmonary embolism, which can occur in these patients, and then also enlarging or expanding pleural effusions. And so oftentimes we see these patients and try to differentiate which one is contributing the most to their symptoms. Importantly, we should realize that once they do recur, it is pretty chemo-insensitive tumor, and so we often then look for other treatments for these patients.
Thank you, Dr. Silvestri. Dr. Higgins, what is consolidated thoracic radiation?
So what that refers to is giving radiation to the chest after frontline systemic therapy. And typically when that is done, the radiation doses tend to be more modest, anywhere between 30 to 45 gray. So we're not talking about 6 weeks of radiation like you would give in limited stage small cell or non-small cell lung cancer that's curable. It's a shorter course of radiation that targets that disease that is left after your chemotherapy. There was another trial in Europe, the Crest Trial, that studied the utility of thoracic radiation after chemotherapy. And in this trial, there was a 2-year survival benefit if you gave thoracic radiation after chemotherapy, with the survival 13% versus 3%. There's a little bit of controversy around this, though, because the primary endpoint of the trial was actually 1-year overall survival, and that was not statistically significant. So, some people argue about whether or not this trial was positive or negative. Should we do thoracic radiation after chemotherapy? And I will say, in the United States, it's really variable depending on the preferences of your institution and really, as a radiation oncologist, the preferences of your medical oncologist if they want to refer the patient. Now, I will say there's a subset analysis of the Crest trial that shows the patients that derived the most benefit from consolidated thoracic radiation were those patients that had residual cancer in their chest after chemotherapy.
Yeah, there does seem to be some benefit to a subset of patients. I think the numbers out to 2 years are a little small, but certainly a reasonable practice. I think overall, with or without consolidated radiation, the prognosis for small cell lung cancer has been very poor. And prior to immunotherapy, we'd not seen our standard approach change for 3 or 4 decades. Now, that's not for lack of trying. There have been dozens of failed phase 3 trials that simply were unable to improve survival in small cell lung cancer. Thankfully, that has finally changed with the integration of immunotherapy, a modality that has succeeded where really so many others have failed.
Thank you to all of our panelists for an insightful discussion about the foundational aspects of small cell lung cancer and for providing some historical context. What a long, challenging road it has been to improve outcomes for our patients. So let's now focus on why there is new hope for our patients thanks to the emergence of immunotherapies. The biggest advance in recent years for small cell lung cancer has been the introduction of immunotherapy. Dr. Liu, what was the rationale for exploring immunotherapy in this disease?
Well, immunotherapy has been active in a lot of different cancers. It's really changed oncology. We learned fairly early on that outcomes seem to be better in cancers that were related to carcinogens. That certainly describes small cell lung cancer with its connection to smoking. Cancers with a high tumor mutational burden, or TMB, which refers to a large number of somatic mutations, also seem to do better. And small cell lung cancer, as this table illustrates, has one of the higher rates of somatic mutations. This kind of ties into how immunotherapy works. Presumably, more mutations will lead to more neoantigens, right, Dr. Goldman?
Exactly. And these neoantigens are what then could be processed by antigen-presenting cells and lead to an immune response. The way I think about it is that some of the times the immune system is able to evade, the cancer is able to evade the immune system via these checkpoint proteins, CTLA4 and PD-L1. Anti-CTLA4 and anti-PD-L1 or PD-1 antibodies block this turn-off switch and thereby allow the immune system to be active and fight the cancer.
Thank you, Dr. Goldman. Dr. Liu, can you review some of the early clinical data with immunotherapy in small cell lung cancer?
Sure. One of the first major efforts was the non-randomized Checkmate 032 trial that explored nivolumab, a PD-1 inhibitor, either alone or with a CTLA4 inhibitor, ipilimumab. This study showed a modest response rate. This table shows about 10 to 23%, and actually relatively low progression-free survival. But what stood out to us was really the landmark overall survival rates, which were far above what we would expect. This is a heavily pretreated small cell lung cancer population, and survival really is quite limited. But in this study, as the Kaplan-Meier curves show, we have up to 26% of patients alive 2 years into therapy. It's really that potential for durable response, for long-term meaningful survival that makes immunotherapy appealing. And this benefit was consistent. It really was a class effect. We saw this with other checkpoint inhibitors, for example, Pembrolizumab.
Here, we'll be able to pick up on the somewhat similar data with Pembrolizumab. Two trials, the Keynote-028 trial in PD-L1 positive small cell lung cancer, and the Keynote-158 trial in a mixture of PD-L1 negative and PD-L1 positive small cell. Both of these single-arm trials, the data was combined to look at 131 patients. The response rate here was described as 16%. And again, there are some patients that are having significant benefits out approaching a year and beyond. This led to some FDA approvals, both for nivolumab in third-line small cell, as well as pembrolizumab, similar indication in third line, all based on these single-arm data sets. Due to further study with nivolumab in a randomized setting, which did not confirm a survival benefit, the nivolumab approval was recently withdrawn.
Dr. Goldman, those are some really important data, but I'm really concerned about the attrition rate, especially in the third line setting, which really limits maybe its usefulness. As you can see from this slide, in 432 patients with extensive stage small cell lung cancer, almost all of them, 93%, received first-line therapy. However, only 50% or half receive second-line therapy. And by the time you get to third-line therapy, it's only 22%. And the response rate among that 22% is quite low. And we really need transformative drugs to improve the potential impact.
Thank you, Dr. Silvestri. But immunotherapy agents are potentially transformative agents, at least for some patients. What strategies are there to increase the impact of this class of drugs?
There have been two approaches to bringing immunotherapy earlier in the treatment course. One is, of course, second line. This trial of nivolumab versus other approved agents, topotecan or amrubicin, in the second line. This, unfortunately, did not show an improvement in overall survival, and in fact, progression-free survival looked substantially worse. The other approach has been in the maintenance phase. After 4 to 6 cycles of initial platinum-based chemotherapy, patients were randomized to nivolumab or nivolumab with ipilimumab or placebo. Here we have the curves, really a negative trial and not a convincing benefit in the maintenance phase.
Well, that's certainly disappointing and perhaps a bit surprising.
Yes, I think it is. And I think we should all continue to realize that the best chance for us to make a headway with small cell lung cancer, extensive stage small cell lung cancer, is in the first line setting. And that's where we're really trying to add to our treatment courses, because it's very refractory once you get into the second and third line setting, as Dr. Goldman mentioned.
Thank you, Dr. Silvestri. Dr. Liu, can you tell us about the first-line data?
Sure. I mean, I can't underscore Dr. Silvestri's point enough. The real opportunity here is in the frontline setting, where we're building not just on the synergy of a chemo immunotherapy approach, but really avoiding that rapid and significant attrition that really characterizes small cell lung cancer. And the first study to explore that strategy was Empower 133. Empower 133 was a global, randomized, double-blind, placebo-controlled phase 3 trial for patients with untreated small cell lung cancer. They received standard carboplatin AUC5 on day 1, etoposide 100 milligrams per meter squared days 1 through 3, and randomized 1-to-1 to receive concurrent atezolizumab, a PD-L1 inhibitor, or placebo, followed by atezo or placebo maintenance. Primary endpoints here were progression-free survival and overall survival. And as we learned in 2018, this was a positive study, meeting both of its endpoints. There was a modest improvement in progression-free survival with a hazard ratio of 0.77, but most importantly, this study achieved that elusive improvement in overall survival. The survival improved from a median of 10.3 to 12.3 months with a hazard ratio of 0.70, a 30% reduction in the risk of death, and a one-year survival rate that was at 52% compared to 36% with placebo. Now, in this Kaplan-Meier curve graph, you might notice that it appears the curves seem to come together at 18 months, but understand it's very unstable there. With more follow-up, we see that difference at 18 months is identical to the difference at 12 months. That survival benefit persists. And importantly for our patients, the addition of atezolizumab improves progression-free survival, improves overall survival, improves quality of life without significantly worsening toxicity. This study led to the approval of atezolizumab as part of frontline therapy for extensive-stage small cell lung cancer in March 2019. It's a significant study. We waited almost 4 decades to see the first trial with any impact on survival, although it was less than a year later that we saw the second. Dr. Goldman?
The Caspian trial is also a large international trial to evaluate the addition of immune checkpoint therapy to first-line chemotherapy in extensive-stage small cell lung cancer. Over 800 subjects were randomized to one of 3 arms. One was chemotherapy alone. Second was chemotherapy with durvalumab, the PD-L1 inhibitor, and the third arm was chemotherapy, durvalumab, and the CTLA-4 inhibitor, tremelimumab. In this trial, the platinum agent could be either carboplatin or cisplatin, and the chemo alone arm went to 6 cycles, and PCI was allowed in order to make this comparison arm as robust as possible. The overall survival curves, as seen here, show that the addition of durvalumab led to a meaningful improvement in overall survival with a hazard ratio of 0.73. The survival curves separate at around the time that chemotherapy was completed, and they stay separate through the course of follow-up. This was even more clear at the updated analysis that we just published last month. At the landmark time points of 12, 18, and 24 months, survival is improved with durvalumab, and a little over 1 in 5 patients is alive after 2 years, an outcome that really would not have been expected prior to immune therapy. If we look at that third arm with tremelimumab, it is not adding much, and perhaps due to associated toxicities, there's an early dip in that curve. Based on this data, along with safety results showing, especially in the durvalumab arm, there was little increase in serious toxicities with the immune checkpoint inhibitor. And this led to FDA approval in spring of last year.
Thank you, Dr. Goldman. Now we have 2 new standards of care featuring chemo immunotherapy for extensive stage small cell lung cancer. We discussed incorporation of radiation with chemotherapy. Is there a similar role for chemo immunotherapy? Dr. Higgins.
So that's a great question. There have been exciting preclinical studies that show synergy between radiation and immunotherapy. And certainly we've seen great success using that approach in stage 3 non-small cell lung cancer. So now we're starting to ask the question, could there be synergy with immunotherapy and thoracic radiation for extensive stage small cell lung cancer patients? The Energy Oncology Cooperative Group recently launched a trial asking that question in August of 2020. And this trial will randomize patients after 4 cycles of chemotherapy and atezolizumab to either maintenance atezolizumab alone or thoracic radiation, as well as radiation to other distant metastatic sites, up to 5 sites in total, followed by maintenance immunotherapy. And that's a phase 2/3 trial that will enroll a little over 300 patients. And it will really answer the question as to whether or not thoracic radiation should be given now that we have a new standard of care in terms of the systemic therapy used in extensive stage disease. There's also another trial, the Adriatic trial, that is looking at giving immunotherapy after concurrent chemoradiation in limited stage disease. In this trial, patients will receive their concurrent concurrent chemoradiation, and PCI, and then they get randomized to immunotherapy with either durvalumab, durva-tremi, or placebo. And that trial is currently underway. It's enrolling actively in the United States as well as outside of the United States.
Thank you, Dr. Higgins. We've talked a lot about the potentially substantial benefit of immunotherapy. What about toxicity? Dr. Silvestri, are there toxicities that you're concerned about?
Yes, for sure. And I think pulmonologists are seeing this more and more, actually reported a bit more than were in the trial. Not just pneumonitis, which I'm going to talk about in a moment, but rheumatologic findings, GI findings, dermatologic findings. The immune system is revved up, and occasionally it can attack itself. It can attack the human body. When we see this in patients, though, from the pneumonitis perspective, what we see is generally 1 to 6 weeks after immunotherapy is given. You see where the patient, the x-ray on the left, the baseline x-ray with the tumor in the right lower lobe. And then what you see on the right side is this sort of peripheral bilateral ground glass opacities. Initially, when we saw these patients, we were doing bronchoscopy and other forms of making a diagnosis. Now we follow either the NCCN or other guidelines where we stop the medication. Sometimes the patients are completely asymptomatic, and sometimes they can be even re-challenged, up to and including using steroids in patients who have dyspnea and have severe respiratory dysfunction and oxygen desaturation. One thing I will tell you is even if you stop the immunotherapy, their immune system can stay revved up for a long period of time. And sadly, a small number of these patients, a very low proportion of these patients, can march right through steroids and even die from this. So you have to keep an eye out for it. Most of the time, we're not doing bronchoscopy anymore. We're looking at clinical and radiographic symptoms and either stopping the drug and watching or stopping the drug and immediately starting steroids for this patient population.
Thank you, Dr. Silvestri. Dr. Manzano, do you see other toxicities in your patients receiving immunotherapy?
Definitely, Patricia. The truth is any organ system can potentially be affected, as you can see on this slide. So from endocrine to musculoskeletal, respiratory, as Dr. Silvestri had described, GI, renal, neurologic, including the skin. So very often the symptoms are very nonspecific. I think that's one thing to remember about this. And one must just really have a high index of suspicion for immune-related adverse events. Take, for example, fatigue. Could be from any endocrinopathy and be a marker for adrenal insufficiency, hypothyroidism, hypopituitarism, hypophysitis. Myalgias and joint pains could be from myositis or inflammatory arthritis from immune therapy. And sometimes these manifestations can occur together. We have overlap syndromes. Myocarditis, which is often a very severe finding, can be associated with myositis. So it's again, very important to have high suspicion. And it's really important to recognize that the patient's presentation could potentially be from a toxicity. There are organ toxicity specific algorithms for evaluation and management, and that can often be a very multidisciplinary endeavor as well. I want to emphasize multidisciplinary collaboration and consensus here. It's really important that we make sure that the appropriate decisions are made in terms of holding the immune therapy or not, initiating toxicity-directed treatment. As Dr. Silvestri mentioned, very commonly we start with steroids. In some cases where they do not respond or they progress even more, we may have to initiate other immunosuppressive therapy. As a hospitalist, though, and speaking to other colleagues, I do find that the biggest challenge is when patients present with a potential toxicity, perhaps in an ER in an institution other than where they get cancer treatment, and that outside physician does not know that the patient is on immune therapy, so they don't suspect it. So if I may ask our oncologist, Dr. Liu, apart from patient education, do you have strategies to ensure that the patient is able to communicate to other healthcare providers that they are on immune therapy? I think that's very important.
It's a good point. It's not going to be on your differential if you don't know they've received immunotherapy at some point in their past. And so a lot of our patients will carry wallet cards that we make that sort of explain what drug they've received and when they've received it. Those are helpful. But I think the most important part is just to make sure the patient themselves are educated. They know what they've received. They know the potential risks, even far down the line, as Dr. Silvestri mentioned, and making sure the family knows and caregivers know as well, so they can communicate with their different caregivers throughout their life.
Thank you, Dr. Liu. What do you think is next for small cell lung cancer, Dr. Goldman?
What a great question. We really have made strides, but we have a lot of work left to do. I tried to put many of the new therapies on this slide, showing, in addition to lurbinectedin, which I spoke about previously, a response rate of about 35% led to accelerated approval. We're now looking at new classes of drugs. PARP inhibitors have shown some benefit, which we believe can be augmented with a second chemotherapy, for example, temozolomide. Anifarago reported a response rate of 40% with olaparib with temozolomide. And we're working on similar combinations with talazoparib and temozolomide in an early study. And we have second-line and maintenance therapies that are underway. Other agents include liposomal irinotecan. In an early report, a response rate of 44% was reported, as well as other more active immunotherapies. BiTEs and CARs have been described to markers such as DLL3, which are clearly upregulated in small cell lung cancer. These may be ways to either bring activated lymphocytes to the tumor cells or to actually almost short circuit the system in order to immediately get an activated T cell into the patient and to fight the cancer. One of the wonderful things about the advances that we've discussed is that's led to more research, and we hope accelerated improvements in patient care.
Well, I think we'll continue to see trials building on those first-line chemo immunotherapy regimens, building on that atezo or durva backbone by adding other agents, other immunomodulators like PARP inhibitors, other checkpoint inhibitors like those targeting TIGIT. For me, though, the next major breakthrough is going to require development of biomarkers to really help identify unique subsets within small cell lung cancer so we can develop and deliver these drugs where they're really going to be more active. And hopefully, in the coming years, we'll also be able to extend some of these advances to limited stage small cell lung cancer. And I think that's an area where Dr. Higgins is working.
Well, we certainly hope that we'll see improved outcomes with immunotherapy and limited stage disease, where the standard of care also has not changed in several decades. And NRG Oncology LU005 is a phase 2/3 randomized trial where we're adding in atezolizumab concurrently with chemoradiation and then continuing it on for 12 months. And the goal of this trial is really to test if immunotherapy will improve overall survival in limited stage disease.
It has been exciting to hear about all the new practice-changing advances with immunotherapies in small cell lung cancer. It's also great to hear that there's so much more hope and several emerging options on the horizon. In this last section, we'll highlight the team approach using a case study. Dr. Manzano, could you present the case, please?
Of course, Patricia. So this is a fairly typical case. We have a 65-year-old male smoker who presents with dyspnea and cough over several months. We have imaging that shows a large mediastinal mass, liver metastases, and we detect 2 small asymptomatic brain metastases. Dr. Silvestri, what would your biopsy approach be in this case?
Yeah, just for a moment before I get to the biopsy, this is absolutely critical that we start with really good communication. If this patient were an inpatient on the hospitalist service, talking to the hospitalist, getting to know them, getting to know the patient is really important. And then bringing together your team. You know that this is a central mass. It might be small cell. You may want to alert your pathologist to that. Just communication here is really central. For us, we would suggest a liver biopsy because we don't know yet whether it's non-small cell or small cell, and therefore we would do a liver biopsy that could give us both a diagnosis and a stage simultaneously. So that would be the way to go, and it's a really safe procedure.
So in this case, a liver biopsy was done and we confirmed small cell lung cancer. I would typically refer right away to our medical oncologist. But in this particular case, the patient had two asymptomatic brain metastases, so no neurologic deficits whatsoever. Dr. Higgins, could you comment on this? Should I refer to radiation oncology from the get-go?
So I think in the setting of chemo immunotherapy, the management of brain metastasis in extensive stage disease is becoming more nuanced. So for example, in the Caspian trial, patients with asymptomatic brain metastasis were allowed to proceed with chemo immunotherapy. And certainly, and somebody with sub-centimeter brain lesions who is not having any symptoms, I would feel okay with this approach, as long as we followed the patient up with brain imaging to continue to take a look at those lesions and make sure that they're not growing or causing the patient symptoms. Now, in terms of the type of radiation that we use for small cell lung cancer brain metastasis, the standard of care for many years has been whole brain radiation given in 10 fractions over a 2-week time course. There's a lot of side effects with this approach, including fatigue and cognitive changes, and it can delay the delivery of that systemic therapy that is very important for this cancer that progresses quite rapidly. So now radiation oncologists are starting to look at more focused radiation in the brain, something called stereotactic radiosurgery. There's a trial through NRG Oncology that will open very soon that will randomize small cell lung cancer brain metastasis patients to SRS treatment or whole brain radiation. And then we'll really know the answer as to whether or not that more targeted radiation is an option for patients with small cell lung cancer brain metastasis. Now, I would say certainly if the patient was symptomatic from these lesions, you should go ahead and get the brain treated so that they can continue on with their systemic therapy and you don't have to worry about worsening neurologic symptoms.
Thanks, Dr. Higgins. So if this particular case presented in the clinic in the outpatient setting, Dr. Liu, could I ask, what would your approach be for this patient in terms of a treatment plan?
Right. Well, we've established an extensive stage small cell lung cancer. If there are no contraindications to immunotherapy, that's a pretty short list. Our preferred standard treatment is concurrent chemo immunotherapy. I would use a PD-L1 inhibitor, either atezolizumab or durvalumab with carboplatin and etoposide. In that setting, I'm expecting a response. The true test will really be the durability of that response and the length of survival. Now, if I may continue the case, let's say we proceed with treatment. He has 4 cycles of concurrent chemo immunotherapy and then continues that immunotherapy maintenance approach once every 4 weeks. He has whole brain radiation therapy after induction during maintenance. No need to interrupt treatment there. We have a CT scan during maintenance that shows a good response, but about 2 months after that CT scan, this patient develops dyspnea. He's urged to come into the clinic on the same day and found to be newly hypoxic, mildly hypoxic, but a new oxygen requirement. So we have new dyspnea, new hypoxia, about 2 months after our CT scan on immunotherapy. So why don't I throw it to Dr. Goldman? What's going on in your mind right now if you see this patient in clinic?
Well, this is a relatively common situation. This is around the time that patients may develop refractory disease to their first-line therapy. So certainly disease progression is in the differential. But as always, we should maintain a broader differential, toxicity to immune therapy, as well as pneumonia or the development of a pleural effusion. All of those are in the differential. A physical exam, of course, maybe a quick chest x-ray in the clinic if you have availability for that. But often the real diagnosis does require, particularly if the patient is symptomatic and hypoxic, rapidly going to a CT scan. A CT angiogram of the chest also allows you to rule out pulmonary embolism, but the primary differential will be cancer progression versus treatment toxicity, pneumonitis, and then rarely other things like pneumonia. Usually you'll identify that with the rapid onset and fever, for example. The CT scan, though, is usually definitive and often will be reviewed with a pulmonologist. Dr. Silvestri, anything to add?
Yes, I certainly would like to add, if we have a CT, everything you mentioned, I think, is incredibly important. The one thing that hasn't really been mentioned today, which is of equal concern, is we've been seeing patients both in our clinic and in the hospital who have unexpected COVID infections. And that can sometimes look like a pneumonitis. And so getting the time frame of when they've been given their immunotherapy, for example, if it's way outside that time frame, of 30 days or even 60 days, and suddenly they have a multifocal infiltrates, particularly in the periphery, you may want to think about a COVID infection in addition to the other things that you so appropriately mentioned, Dr. Goldman.
We have a pretty broad differential here. Dyspnea in someone with a history of small cell lung cancer, presumably a history of smoking, certainly something we might expect to see, but a new dyspnea, a new hypoxia, those to us really are emergencies. And so in this case, we get a same-day CT scan. Dr. Silvestri, I'm going to throw this back to you. Let's say we get this CT scan that you see here. What are your thoughts and your differential? Does this CT scan help you narrow anything down?
Yeah, so you can see in the upper panels at the 428 CT scan, and you don't see much. And then you see this multifocal infiltrate in the lower scans, ground glass opacities, both on the left and the right, more in the periphery than central. And I would certainly think about drug-induced pneumonitis for this CT scan. I don't think it's progression of disease. Again, COVID can look like this, but I think it's most likely pneumonitis.
Now, in this particular case, this patient did not receive radiation, but one thing that I often struggle with in my clinic is distinguishing between radiation pneumonitis and immune-mediated pneumonitis. Dr. Silvestri, any tips in your own experience?
Well, there are two forms of radiation pneumonitis. One's a very focal form of radiation pneumonitis, right in the window where the radiation is given, and it's often right around the mass. There's a sort of technical term called the straight sign line, which is a straight line up and down that really looks like the port itself and doesn't respect the fissures. And then there's sort of this generalized immune-mediated pneumonitis that can look like drug-induced pneumonitis. And again, here's where trying to differentiate and use your timeline to try to differentiate between which drug was which treatment was given. Was it the drug given and 30 days later you're seeing this, or was it radiation completed 2 years ago? Then it makes radiation less likely. And again, sometimes you just can't tell. By the way, both are treated with the same sort of treatment, right? You would stop the therapy and give steroids. So not that it doesn't make a difference. The really important point here to try to distinguish the two is because immunotherapy may be our last hope for this patient. And so we sometimes would like to make sure it's not the pneumonitis related to immunotherapy so we can continue the drug or re-challenge the patient with the drug.
Thanks, Dr. Silvestri. Now, just to make this a little more complex, this actual image is from someone who was receiving checkpoint inhibitors, did develop these very symptoms, but the diagnosis in this case was actually miliary tuberculosis. For sort of unclear reasons, when you receive a PD-1 or PD-L1 inhibitor, it completely disables your defense against Mycobacteria tuberculosis. And so for patients with latent TB, suppression of that is important when you're receiving immunotherapy. If you're practicing in an area where TB is endemic, know that checkpoint inhibitors will really lead to reactivation of TB. And so add one more thing to the differential here.
Absolutely. And look, TB can look like anything, and we often get surprised. And again, if you're in South Texas, if you're in even in South Carolina where we have usual TB, you have to look for that. And we often ask right at the beginning of treatment for any of the cancers, have you ever been exposed to tuberculosis? And if they have a positive PPD or exposure, we will treat them as we start therapy for latent TB with INH and B6.
All right, well, thank you for this great practical discussion. To conclude, can each of you please reflect on what we've discussed today and share your key takeaways to our audience? Dr. Liu, we'll begin with you.
Sure. I mean, immunotherapy is, there's no question, this is a major advance for small cell lung cancer and a new standard of care. When we add a PD-L1 inhibitor to frontline platinum etoposide chemotherapy, we improve survival. Now, not everyone derives that benefit, and I appreciate the degree of benefit is not as great as we'd like. We do need biomarkers to help direct treatment where it can be most impactful. But right now, we have a subset of patients with this exceptionally lethal disease, small cell lung cancer, who can achieve long-term survival. And we have to ensure we provide the opportunity for patients to get there.
That was great, Dr. Liu. I think I just really want to stress the importance of the multidisciplinary team. Small cell lung cancer has changed so much with chemo immunotherapy as our new systemic therapy backbone. And for radiation oncologists, this really impacts when and how we deliver radiation. You don't have to treat every brain metastasis at the onset of diagnosis now. You need to pick up the phone and talk to your medical oncologist and determine what sort of timing it makes the most sense for each individual patient. I also want to mention that it's very important to evaluate our patients for clinical trials as well, so we can continue to move the needle for extensive stage disease. And I'm hopeful that chemo immunotherapy will move the needle in limited stage small cell lung cancer as well.
You know, in addition to highlighting the toxicity and the pneumonitis, I really do want to speak to pulmonologists directly and firmly to say that, look, this no longer is a disease where we just make a diagnosis and send them on to palliative care. Pulmonologists need to understand we have an obligation to refer these patients quickly because their quality of life can be improved and their survivorship can be improved. So for me, this nihilism that we've shown for patients with lung cancer, it really has to be overcome. Many patients with lung cancer have a long-standing relationship with their pulmonologist because they might have COPD related to smoking or other pulmonary-related diseases. They trust their pulmonologist, and we're often the first person they see on the way through the diagnostic and treatment journey. So please, for pulmonologists, get out there and make sure that you're referring your patients appropriately for further care to a multidisciplinary team.
So as an oncology hospitalist, we do see these patients with extensive stage small cell lung cancer often presenting to our institutions with very high acuity on initial diagnosis, and especially when there's disease progression also. So I think one key takeaway is the urgency of treating once a diagnosis is made, not waiting for the outpatient setting, getting the medical oncologist on board and the rest of the treatment team. As Dr. Higgins mentioned, we cannot overemphasize enough communication with other treating teams, coordination of care between the inpatient and the outpatient teams specifically. And that includes when even we see immunotherapy-related adverse events or toxicities, because that consensus between the treating teams is really important to make decisions that would impact cancer outcomes.
And we, as the physicians, our patients, and their families, we now have a clear reason for hope, for benefit, and at times very significant benefit from our therapies. We also have a lot of work to do to keep on doing research and continue to bring advanced and improved outcomes for our patients.
Well, thank you everyone for your key takeaways. Thanks so much and have a great evening.
This activity has been jointly provided by Medical Learning Institute, Incorporated and PVI, Peerview Institute for Medical Education.